Hello everyone. I hope you can hear me well. So I'd like us to start our day by welcoming you to today's CME, introducing myself, XYZ, and our speaker before handing over the floor to the speaker. So I am your moderator today. Eric Mutua is my name. I'm a year 4 at Egerton, studying MBCHB. When I'm not busy in class, I like running and reading fiction by African authors about Africa, and currently I'm interested in pediatrics and medical education advocacy. That said, I would like to introduce any first-timers to the organizers of this noble initiative, who are XYZ Med, a vibrant community of Kenyan medical students from multiple universities united by the mission to enhance medical education in Kenya. This initiative is driven by the need to create accessible, locally relevant, and tailored resources that directly address the country's unique healthcare challenges. The current medical education system in Kenya frequently depends on foreign resources, which may not always feel relatable in our local context. This gap may leave healthcare professionals less prepared and contributes to limitations in public awareness regarding various medical conditions. XYZ Med, the organizers, are trying to bridge this divide by developing a wide range of educational tools and initiatives. One such initiative is this CME series, designed to promote peer-to-peer learning. Other tools include contextualized medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, etc. There are a lot of other tools being used. And with that introduction done, I would like to introduce our CME topic and our speaker of today, or our peer educator. So the CME topic is intestinal obstruction, and our speaker is none other than Ayaan Hassan, final year medical student at the University of Nairobi, who has a deep passion for learning and sharing knowledge. And in her free time, she enjoys binging Friends, which I think is her real superpower, because enduring hours of Friends laugh tracks is no joke. So yeah, Ayaan Hassan, thank you, and please, you're welcome. The floor is yours.
Hello, good morning, guys. Please confirm if you can hear me.
Good morning, we can hear you.
Okay, thank you. First of all, I'd like to start by asking you guys to excuse the background noise. I'm at a workshop and they have music going on at the lobby. Second, Eric, thank you very, very much for that very well thought out introduction. But I'd like to say no friend's what is it called, slander is tolerated here, so we're gonna have to talk in my attent. But with that being said, the topic today is intestinal obstruction. Thank you, Felix, for allowing me to present this today. So I actually had to can you guys hear me?
Yes, we can hear you, Ayaan.
Okay, perfect. So I actually had a bit of a hiccup where I lost my whole presentation and I had to make it again in a hurry this morning. So just bear with me in case you see any discrepancies or anything that's not adding up. Maybe I'll explain it better in by word. So maybe we can start now. We can go to the next slide. So what is intestinal obstruction? Also called bowel obstruction. So this is when there is an interruption in the normal passage of bowel contents through the normal passage of content through the bowel. So anywhere from when food goes through the pyloric sphincter all the way to the anal sphincter, we can have an obstruction. So an obstruction at any point from the pyloric sphincter to the anal sphincter is going to now be called an intestinal obstruction. So it can be divided according to extent. This also can be, so the partial or complete constipation is also a what is it called? Sub-classification of mechanical obstruction, which we will come to see. Just from the name, it can be partial, meaning the whole lumen is not obstructed. There's a bit of the lumen the integrity of the lumen is not fully impacted. So, or you can have complete obstruction, which is also called obstipation. Another way of dividing it is also according to cause or mechanism. So it can be either functional or mechanical obstruction. So when we say functional, we are talking about the peristalsis, and the fact that the peristalsis is not there, and it's not an issue of whether the lumen is impacted or not. There's an issue with the peristalsis of the lumen. When we talk about mechanical now, that means there is something that's impacted in the lumen. It can be, obviously, it's going to be the food that the person has ingested, but peristalsis would be there. Obviously, it would be decreased or absent. So can we go to the next slide? Yes. So this is just what I've said. Functional obstruction, also called paralytic ileus, meaning there's no peristalsis, so the ileus is the lumen is essentially paralyzed, and it's usually temporary. So also called paralytic ileus is the temporary disturbance of peristalsis in the absence of mechanical obstruction. Again, what I've said, that there is an interruption in the peristalsis, but there is nothing impacting the lumen. So how do you have this post-surgery? So immediately after intra-abdominal surgery, to be specific, you're going to have a bit of a period where there's paralytic ileus. If there's peritonitis, until that peritonitis is sorted out, it could lead to paralytic ileus. Trauma, metabolic or endocrine pathologies, diabetes mellitus, hypothyroidism. We know it's going to be the hypothyroidism is going to cause so essentially hypothyroidism, everything goes down. So that peristalsis also decreases. Hypokalemia, iatrogenic causes. So if someone is on anticholinergics or opioids. For mechanical obstruction now where we're going to focus majorly on for today, is where there's an interruption of the normal passage through the bowel. So meaning there's a structural barrier. So now this one is further subclassified into large bowel obstruction, small bowel obstruction, or a gastric outlet obstruction, which is, there's really not much on it. So we're going to really focus on the large bowel and the small bowel obstruction. What are the different causes? How do they manifest? How to deal with them? Next page. Okay, so what are the causes of a mechanical obstruction? You can have, so the first one is essentially, so that you can see that different boxes. So the first one is the most common cause. The second one are other less common causes, and the third box would be for specific to infants and children. So for the most common causes for small bowel obstruction, it's going to be adhesions, majorly post-surgery. You can have post-surgery or even something like abdominal tuberculosis. This is going to cause adhesions. Essentially, we know adhesions is when you have a scar tissue forming between an organ and between adjacent organs or tissues, right? So if you have tuberculosis and or essentially as a complication of a surgery that has been done recently, there's going to be that fibrous scar tissue that is going to form, and that is going to cause adhesion. I really hope this background noise is not too loud. Is it too loud?
It isn't too loud.
Okay, perfect. So that is the first one. So you have that scar tissue forming, and these neighboring tissues or organs are not usually physiologically connected. So this is essentially a pathology, right? The next one is hernia, right? So we all know hernias. Other causes are Meckel's diverticulum, strictures, for example, in Crohn's disease. We can have ascariasis, where we know they're so big that they can actually cause impaction in the lumen. You can have an internal hernia where the hernia, instead of coming to the anterior abdominal wall, it goes other way. Or you can have foreign body impaction. Maybe this would be common in children that just ingest anything. You can have children ingesting coins and stuff like that. So depending on the size of the thing that has been ingested, it's going to cause an obstruction, or maybe it's just going to pass normally. So specifically for infants and children, the causes of small bowel obstruction would be a congenital intestinal atresia. So you have duodenal atresia, jejunal atresia, particularly in children with Down syndrome. They usually present with this. You can have interoception, where you have telescoping of the lumen. So the proximal part telescopes into the distal part, and obviously that is going to cause an obstruction, and congenital strictures. When we come to the large bowel obstruction, the most common causes, as opposed to the small bowel, which is the bowel adhesions, this one is going to be malignant tumors. And the most common tumor is colorectal carcinoma. So now you come diverticulitis, volvulus. Those are your most common causes of large bowel obstruction. Adhesions is not so common as opposed to small bowel. Strictures as well is not so common. Fecalith is when you have now the feces is so hard that it actually forms a hard ball and obstructs the lumen. And then you can have, again, foreign body impaction. When it comes to children, we can have Hirschsprung disease, where it is a ganglionic megacolon. Essentially, the neural crest cells do not descend all the way, and you have a portion of the large bowel that does not have nerves. You remember there was, I think, the Auerbach and the two sets, the ones in the mesentery, the muscular portion. Essentially, the two different sets of the nerves do not come through, and we have malabsorption, and we have why am I blanking out? We have malabsorption, and we have this obstruction, meaning there's no peristalsis, right? Congenital strictures, meconium ileus, now particularly in infants, and rectal atresia, where the rectum essentially is narrowed. Next. Actually, before we go to next, there's also another classification that I did not really focus on, where there is extrinsic bowel obstruction, there's an intrinsic bowel obstruction. I have not included it here, but I think we can gauge from the wording what can cause it. So when we talk about extrinsic bowel obstruction, it's a external compression of the bowel. So meaning intramurally or within the lumen, there's nothing obstructing it. The obstruction is coming from the outside of the lumen. So the things we've talked about, the list is still here, but now the classification sort of changes. Okay, instead of focusing on the location of the pathology, now we're instead of classifying it into small bowel and large bowel, we're now classifying it into extrinsic and intrinsic. Okay, so adhesions would be extrinsic, a volvulus would be extrinsic, a mass would be extrinsic, and a hernia would be extrinsic. When we come to intrinsic, we're talking about things like strictures, intestinal tumors like the lymphoma, the colorectal carcinomas, diverticulitis, interoception, these foreign body ingestions, the fecalith, all of these now become intrinsic bowel obstruction. I hope I'm making sense. So you can also classify it in that manner. You can classify it etiology according to location. So small bowel or large bowel, or location in terms of extrinsic and intrinsic. But the etiology itself does not change. Yani diverticulitis, now you just rather place it in SBO or LBO or intramural or extramural. I hope I'm making sense. Next. So what is the pathophysiology of what happens then when there's an intestinal obstruction? Okay, so obviously there's an obstruction, and then that is going to cause stasis of luminal contents, right? So if the luminal contents are not going, that means also gas is going to be impacted in there. that is going to increase intraluminal pressure. What is that going to lead to? It's going to lead to distension, right? And then that distension is going to increase the space between the cells. So there's going to be sequestration of fluids within the distended bowel loops. So essentially what we call that spacing, and this is going to lead to dehydration and hypovolemia, right? So we can already see some of our symptoms coming in. Another thing, if the food is not, the food is not going out through the other end, which is the anus, obviously blood pressure is going to increase and it's going to cause it to come back up. So you're going to have vomiting. This vomiting can either be bilious or fecal vomiting, which we're going to see later on. But vomiting is going to happen, and we already know loss of fluid and sodium and potassium and hydrogen. Chloride is going to cause all these metabolic disturbances. So your metabolic disturbances coming from there. You have that distension again is going to cause compression of the veins and the lymphatics, right? So this is going to lead to edema. That edema is going to cause compression of intestinal arterioles and capillaries. This is now going to cause ischemia. Now, what happens when you have ischemia? Again, bowel permeability increases. You're going to have the microbes that were initially intestinal. They're going to come to the peritoneum. This is going to cause sepsis. Now we're starting to see the complications, or the, what are they called? The red flag symptoms that you should look out for in someone who has intestinal obstruction. You're going to have necrosis and perforation of the wall because, again, the vascular integrity has been compromised. So obviously, necrosis and perforation of that wall, which is going to lead to peritonitis. You're going to have anaerobic metabolism and lysis of these ischemic cells, because if the cells have died, they have to be cleared out, right? This is going to cause accumulation of lactic acid and release of that intracellular potassium. This is going to lead to, again, metabolic acidosis and hyperkalemia. And you're going to see later on that this increase in lactic acid is one of our telltale signs of complicated intestinal obstruction. So there are cardinal signs, the signs that do not specify if it's a large bowel or a small bowel obstruction, but they just generally tell us that there's a bowel obstruction that has happened. And then we're going to look at the signs that tell us, is it more likely to be a small bowel obstruction or a large bowel obstruction? We're going to look at that in the next slide. So what are these cardinal signs, Yani? We can also call them non-specific signs. You're going to have abdominal pain, obviously. You're going to have vomiting, which I've just talked about, the pathophysiology of it. We have talked about abdominal distension. You're going to have decreased bowel sounds and obviously constipation. Can we go to the next slide? Thank you. So now we are going to look at these and the 5 symptoms that I just mentioned, how to know if it's a small bowel or a large bowel obstruction, right? So when we talk about the abdominal pain, for a small bowel, it's usually periumbilical and it's colicky, meaning it comes and it goes, it comes and it goes. So there's transient periods of lack of pain, right? When you compare it with the large bowel, it usually starts colicky and then it progresses to becoming large, constant pain. So you're constantly in pain. Let's look at the vomiting with the nausea. So usually in small bowel, it's early onset, which makes sense because it's the route that the food has to take back out is shorter. So it just goes back through the stomach and esophagus and it's out. So it's early onset because the food comes back outer. It's larger in volume and it's bilious. Okay. When we compare it to large bowel, it's late onset because think about the route that it has to take back, right? So it's going to take a longer time. It starts initially bilious, but later becoming fecal vomiting because of the content of the large bowel is usually fecal, right? So it will start initially going back. You know, if you have a tube and compress it to Puccini, what is at the top of the tube is going to come out fast. So it's going to start bilious, and then now as that as that pressure keeps on building up, whatever is at the bottom of the tube is going to come out, which in this case it's fecal. So it's going to become fecal vomiting. Constipation or obstipation is late onset in small bowel and early onset in large bowel. When you talk about abdominal distension, it's less severe than in large bowel and early and significant in abdominal distension in large bowel. For your examination findings, pretty much the same, because it's when we talk about examination findings is what you're going to see, and it's not really specific to each and everyone, right? So they're pretty much the same. The both lists are the same. So what you're going to get is dehydration and eventual hypovolemia, which we've already talked about. Abdominal tenderness, which makes sense. If you're going to have that distension, the pressure is going to increase in that. The tympanic, it becomes tympanic on percussion. You're going to have high-pitched bowel sounds early in the disease progression. It's going to be high-pitched bowel sounds, and then later on it becomes absent bowel sounds. And then when you do a DRE, you're going to see that the rectum is collapsed and it's empty. So when you do a DRE, it comes back out clean. Your fingers come out clean. So those are your examination findings. I hope we're together. Next. So we talked about these symptoms, the red flag symptoms that you look for, right? So pain out of proportion, because I think everyone has been constipated at some point or time. So we know what it feels like to be constipated. So you look out for the pain out of proportion. You look out for peritoneal signs, because we said it's going to be rupture. When there's necrosis, there's going to be wall perforation and peritonitis. So you look for peritoneal signs. What are these peritoneal signs? They include rigidity, guarding, increased tenderness, right? So signs of systemic toxicity. So you look for septic shock, essentially. Hemodynamic instability, because we've talked about hypovolemia, right? What do we talk next? We look at your lab abnormalities. We've mentioned metabolic acidosis quite a number of times. We've mentioned increased lactate, which are all which all appear in late stage of this disease, essentially highlighting that there is most probably a complication and it's not a simple process anymore. There's also significant leukocytosis. Next. So what are your lab findings? Okay, so essentially you're supposed to do your initial management. I've just brought the lab findings to just tie everything in, but you're supposed to do your initial management, which obviously you know at this point. You always start with your ABCs. You do your IV bars and everything, which is the next slide. But I just brought it forward to just tie everything in. So this one should come after. Obviously, you can't do what is it called? Lab findings if you have not stabilized your patient, because remember, intestinal obstruction is an emergency. It's very acute, so you cannot just casually just deal with the patient. So you have to be very proactive. So lab findings, you do your CBCs, serum lactate, CRPs. For your supportive findings, you're going to have a patient who's going to be dehydrated, high increased burden creatinine, which is going to indicate prerenal acute kidney injury. You're going to have increased hematocrits. You're going to, so in a patient with recurrent vomiting, these are all things we've seen, by the way, we've already explained: hypochloremic, hypokalemic, metabolic alkalosis, hyponatremia. And then now when you're having what symptoms are suggestive of a bowel obstruction, you're going to have hyperkalemia. You're going to have elevated serum lactate. You're going to have metabolic acidosis, which are all bowel suggestive of bowel ischemia, and we've already seen the pathophysiology of this in a previous slide. You're going to have leukocytosis. You're going to have increased non-specific your inflammatory markers, which are your ESR and CRP, increased amylase and altered coagulation pattern, right? Due to the substance that you have ongoing. So these are your lab findings, but these are not your initial management. So let's go into the management of this condition. So yes, so I've put the management of Punyuma. Just go to the next slide, please. Next. Okay, perfect. So management, no, go back to initial management, the first one. Yes, so For every patient, you have to do your ABCDE approach, because again, this is an acute management. You cannot start treating and you don't know if your patient is hemodynamically unstable, right? So you start with your vital signs, your volume status, if you need to do any intubation or anything, right? ABCD approach. Then you start your initial management, you put the patient on NPO, you obtain two large bore IVs. So one you can give fluids and the other one you take blood for urgent lab studies, which we've already seen. You give them fluid resuscitation, electrolyte repletion as needed. So when you get your lab studies back, you give them electrolyte repletion. You give a nasogastric tube. So this one, usually it helps with, what is it called? It helps with decompression, right? You can also give them a catheter because you're decompressing chini and you're decompressing up as well. So because you don't want any sort of pressure building up at any point in the abdomen, right? So as well as a nasogastric tube, you also give a catheter. And then you start on parenteral analgesics, you give antiemetics, you give your empiric antibiotics, right? But this one now you don't usually give for the simple one. Okay, so if it's like a partial obstruction, you don't really give empiric antibiotics. But you also have to look out for your signs of infection. Do you have fever? Do you have like leukocytosis? Is the pain out of proportion? These ones now you give empiric antibiotics. And then now after you've done all of this is now when you do your lab studies and you go for your imaging, because this is your initial management. So Felix, could we go back to imaging? Is there a slide before this one? Go back one slide. Perfect. Okay. So, no, imaging. Perfect. So your imaging, you have to determine if your patient is hemodynamically stable or hemodynamically unstable, because now you have to choose a different modality, right? So if your patient is hemodynamically unstable, this is supposed to be unstable. Sorry, I'll make the correction. If it's a hemodynamically unstable patient, then you do an abdominal ultrasound or a serial X-ray, okay? But out of the two, an abdominal ultrasound is preferred. Sawa. When we talk about a serial X-ray, you're going to include all the way up to the chest X-ray. So when you start with an abdominal, you obviously have to do either or. You're not doing both of them. So you have different findings and all of them. I'll share the slides. Maybe you can go through the different findings. But you'll see a dilated loop, bowel loops, obviously. You're going to see a thickened bowel wall. You're going to see altered peristalsis. You're going to see intraperitoneal fluid accumulation, depending on what stage the disease progression has reached. If it's leading or going towards complication, then obviously you're going to have that spacing that we talked about, and it's going to manifest in your ultrasound, and you're going to see the intraperitoneal fluid accumulation. For a serial X-ray, obviously, again, you're going to have bowel dilatation. I think this is a free mark you can get. Bowel dilatation is going to be seen regardless of what the imaging is, because of the disease manifestation. You're going to have lack of air distal to the obstruction, which we've talked about. When we talked about an obstruction, we talked about obstruction of both solid content and gas, because an obstruction does not really, there's no way for the gas to move as well. So you're going to see distal to the obstruction, there's going to be no or minimal air. Then you're going to have all your signs. There's a lot of signs in intestinal obstruction: keyboard sign, stepladder sign, target sign, upper core sign. So maybe you go look which disease process is going to be suggestive of which imaging finding, but you have a lot of signs in your imaging. So when we go to hemodynamically stable patient, which is the next slide. Yes, so a hemodynamically stable patient, you do a CT abdomen and pelvis with contrast. This is your gold standard for intestinal obstruction. So your findings are similar to X-ray, but additionally, you're going to have a transition point where you can see a sudden narrowing of the bowel lumen at the site of obstruction. You can also see a closed loop bowel obstruction, which is also a type of mechanical obstruction that I had not mentioned earlier. What if your patient cannot handle radiation exposure, right? So you have to consider that. So your next option is do an MRI. So your patient is hemodynamically stable, but they cannot handle exposure. You do an MRI of the abdomen and pelvis with or without contrast. But now the findings would be similar to CT scan. Okay. What if your patient just has a very distal large bowel obstruction, and we know that the amount of radiation that an MRI gives to a patient is quite high? You can opt for a barium enema. Okay, so you do barium enema or a water-soluble contrast enema. So if the obstruction is very distal, you just do this instead of subjecting your patient to so much radiation from an MRI. Okay, you're going to see tapering of the bowel lumen at the site of the obstruction. You're going to see a bad beak sign, which is seen in volvulus, an apple core sign, which is seen in colonic malignancy. So the signs that are a lot, you have target sign in intussusception. You have so many different signs. So what if the patient has small bowel obstruction, but you want to differentiate if it's a complete or a partial small bowel obstruction? You opt for water-soluble contrast challenge. So if it's a partial obstruction, meaning there's a part of the lumen that's still open, that means that contrast that you've given the patient will reach the large bowel, and it should ideally reach in 24 hours. But if it's a complete bowel obstruction, then obviously that contrast is just going to be cut off at the point of the obstruction. Next. Okay, so we've done the initial management. So we're going to management. So let's go to definitive management of a patient. Next slide. Okay, so what is the definitive management? You can opt for an operative route or a non-operative route. Obviously, it's not all up to you. You also have to consider how your patient is presenting. So when you go for an operative or an interventional, meaning you have to go in and manually disinfect this, this is usually considered in a patient with complicated bowel obstruction and hemodynamically unstable. So you can do a surgery, you can do endoscopic intervention, or you can do stool evacuation. So when do you consider which intervention to take? Okay, so for a surgery, obviously, a stool evacuation will not help you with adhesions if that is the cause of the obstruction. So if the patient has adhesions, a tumor, like we talked about, colorectal tumor, a hernia, you cannot, the only other way of solving this is to go in surgically. So these are some of the indications for going in for surgery for a patient. Endoscopic intervention, meaning you don't have to cut the patient open. What are these indications? Sigmoid volvulus, intraluminal obstruction, inoperable, malignant bowel obstruction. So essentially, you don't need to go in. It's sort of like some sort of stenting, but it's not really, there's not really any stenting. How do I put it? It's more of recanalization of the lumen, if that makes sense, right? So you're trying to manually reopen that lumen, but you're not also trying to open up the patient, right? Or you can do stool evacuation, obviously, if the cause of or the etiology of the intestinal obstruction is fecal impaction or a fecalith, then you can do a stool impaction. So a disimpaction, sorry. So you can either do a distal stool softening or a proximal stool softening. When you talk about distal stool softening, meaning you're going up the rectum, so you're doing an enema, or a proximal stool softening, meaning you're giving them oral oral drugs, so oral polyethylene glycol or sodium phosphate to soften the stool, right? So these are your intervention or operative management. Or when we talk about the non-operative one, which is the next slide. So non-operative management is simple. You consider in a patient that has no complication or is not at risk of developing, sorry, that's supposed to read risk of developing a complication, right? So obviously at that point you should be able to identify if a patient is able to, about to go into hemodynamic instability, or you have some leeway to play with. So, but if you're doing non-operative management, meaning you're doing, as it says here, nasogastric tube insertion or a decompression, it shouldn't take longer than 72 hours for this obstruction to be treated, right? If it's taking more than 72 hours, then you need to go in interventionally, operatively. Sawa. You, for a maximum of 5 days, 3 to 5 days, but you need to also watch your patient so that they don't go into hemodynamic instability. So it also says continuing non-operative management for more than 72 hours does not decrease the need for surgery, but it will increase surgical morbidity. Sawa. So what are the indications for an nasogastric tube insertion? So not routinely required, but it should be considered in the following situations: persistent vomiting, significant upper GI distension, complete bowel obstruction, and volvulus. Because we said it's part of how you decompress. So you do an NG tube above and a catheter chilling. Next. So what are your complications? Complications include the way we've talked about bowel ischemia, bowel perforation, peritonitis. We've talked about all of these things. So you have to watch your patient because this is an acute condition. So if you see any change in the character of the pain of the patient in the examination findings, so rebound tenderness on examination, which is a peritoneal sign. We've talked about signs of sepsis in a patient with bowel obstruction. All of these indicate the onset of complications, and you need to start emergency surgical intervention in this patient. Next. Yes, so that's the end of my presentation. Any questions? I'm really sorry for the background noise.
There was hardly any background noise, Ayaan. Thank you for your nice presentation. Personally, I've learned a lot. So for participants, if you have any questions, you can lift your hand or just unmute and raise it, or you can just write down the question in the chat box. Thank you. Maybe you can give like 2 minutes for that to see if anyone has any questions. Okay, it seems that no one has a question, or yeah, so maybe we can go to the next part of our CME. Just scan the QR code or
Felix, am I
join.
allowed to join? Eric, am I allowed to join this one?
I mean, yeah, you can.
Is there a prize?
Felix might have to clarify on that.
Atuambie haraka.
Yeah.
No, Ayaan, you can't join. You set the questions.
Okay, Ayaan, there seems to be a question in the chat box. Oluochokor asks, what are the possible causes for intestinal pseudo obstruction?
Sorry, what are the?
What are the possible causes of intestinal obstruction?
Pseudo obstruction. So
Yeah,
meaning there's no really obstruction that's going on. There's no real cause of, not real, but there's nothing impacted in the lumen. So when we talk about pseudo obstruction, there's nothing in the lumen, but it's also how do I put it? The lumen, obviously, the best way to put it is the most common cause is now the way we've talked about it, paralytic ileus. When there's no peristalsis ongoing, it means there is obstruction, but the obstruction is not mechanical cause. So it's a pseudo obstruction because there's the lumen, the issue is not coming from the lumen, it's coming from an exterior cause. Am I making sense?
Yes, you are.
Okoth, if I've made sense, give me a thumbs up. Thank you. As the game started.
Oh, excuse me, Ayaan. I'm sorry. I seem to have unmuted and continue
Oh,
talking. There's a
uh-huh.
second. Okay, you asked if the Kahoot has started. It has not started. We're still waiting for people to join in. But there's a second question for you in the chat box.
Oh,
Someone
okay.
is asking, what is the role of colonic angiography in management of intestinal obstruction?
Okay, so colonic angiography. So when we talk about angiography, you're essentially trying to see the blood vessels, right? You're trying to examine the blood vessels. And okay, I'm not an expert, but I'm thinking if because we've not really seen any real cause or any blood vessel related cause of intestinal obstruction. So if there's no real cause of blood vessel obstruction in intestinal obstruction, I don't think colonic angiography has a role in diagnosis of intestinal obstruction. But I also need to do more research on that. But just coming from the small reading that I've done, I don't think it has any role.
Okay, I hope, Kelvin, your question has been answered. Then you have another question from Ngede. He asks, if a patient had intestinal obstruction secondary to adhesion following a surgical procedure, what prevents the patient from getting other adhesions when you go back in to repair it?
Nothing really. I think it's a matter of um, it's a very subjective matter in terms of there's no real saying of who gets adhesions post surgery and who doesn't get an adhesion post surgery. It is a very subjective matter. So highly likely, if you've got an adhesion from one surgery, you might get another adhesion from another surgery. But I don't think that's an indication enough or an incentive enough to not go in and solve the adhesion that's causing an obstruction. So they might get, they might not get, but you still have to go in and fix it because it's a very what is it called? A very subjective matter.
Okay, thank you so much. I think we can now start because our quorum has been reached. Oh. Okay, the first question of our Kahoot is, what is the most common cause of small bowel obstruction in adults? Mhm. Remember, speed also matters and counts to the number of points you accrue. Okay, so the options are okay, maybe we can go to the next question. Which of the following is a common clinical sign of intestinal obstruction? Is it jaundice? Is it abdominal distension? Is it hematuria or is it coughing up blood? Okay, all of us seem to have understood that point. Abdominal distension. Okay. Okay, our third question, which diagnostic imaging modality is most commonly used to diagnose intestinal obstruction? Is it a chest X-ray, an ultrasound, CT scan of the abdomen, or MRI of the abdomen? Okay, CT scan of the abdomen. Only one person got that right. Okay. And Lisan Al-Gaib takes the lead. Okay, so which of the following is a classical feature of large bowel obstruction on imaging? Is it multiple air fluid levels, coffee bean sign, free air under the diaphragm, or pneumatosis intestinalis? Okay. No one got that right. Okay. It's the coffee bean sign. Lisan Al-Gaib is still at the lead. Okay, our fifth question. Which complication is most commonly associated with untreated bowel obstruction? Is it pneumothorax, bowel ischemia? Okay, everyone got that right. Bowel ischemia. Sixth question. The type of intestinal obstruction characterized by twisting of the bowel around its mesenteric axis. Mm. Okay. Many people have like contrasting points on that, but the answer is volvulus. I think we can go to the next one. We have like a new leader on the scoreboard. The seventh question is, in a patient with a small bowel obstruction, the step-ladder appearance on X-ray is suggestive of? Is it gallstone ileus, mechanical obstruction, functional obstruction, or perforated appendicitis? Okay, it's mechanical obstruction. Yeah, as you remember, Ayaan mostly focused on mechanical obstruction. So the eighth question of the day, which of the following is the most likely cause of bowel obstruction in a patient with a history of colorectal cancer? Is it adhesions, intussusception, strangulated hernia, or neoplastic obstruction? Okay, everyone got that right. It's neoplastic obstruction. Okay, me seems to be on a streak right now. Which of the following is the initial management step for a patient with a suspected small bowel obstruction? So the initial management, guys, Okay. So nasogastric tube insertion and fluid resuscitation. IO is on fire at the top of the leaderboard. And our final question. In a patient with suspected bowel ischemia secondary to mesenteric ischemia, what is the most specific diagnostic test? So 5 seconds to go. Okay, we have come to the end of our Kahoot. The answer is CT and geography. Okay. So at our podium at number 3, we have deputy principal. Number 2, IO, and at the top spot, none other than 85. Interesting. So 85 finally grabbed the leader. I mean the top spot from IO. Okay, interesting. I don't know if maybe 85 can introduce themselves or something before we end our CME, our very productive CME.
Hi, Eric.
Hi.
I'm number 85. I'm a bit under the weather, so I wanted to thank Dr. Ayaan for the informative lecture that she has given us.
Okay, thank you. Hope you get well soon. Okay, I think. Oh, also deputy principal and IO can introduce themselves if they're willing to. Yeah. Maybe you can start with deputy principal. Okay. Okay, IO. Okay. IO in the chat box says he's grateful for the great session. Deputy principal, are you with us? Are you still with us? Can you introduce yourself? Okay. I think then at this juncture, I would just like to wish all of you guys to follow XYZZ Med on all platforms, and yeah, you can just follow the link tree shared in the chat box, yeah, so that you can keep on engaging in this noble initiative. Oh, okay. IO says he's Olochokod and he's very grateful. Okay. Once again, thank you, Ayaan, very much. Personally, I've learned a lot, and I think it's the same case for most of our participants. I think that's it.
Thank you guys for joining. Bye.
Okay, goodbye.